Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today, we're going to continue walking through the Blue Book. The Blue Book is the book Mark Klimek wrote. You can get it on Amazon, and we're going to be talking about emphysema. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews. You know, this channel is part of the greater Clinic Review organization that Mark Klimek himself started over 40 years ago. Mark Klimek is the GOAT of Nclex prep, in my opinion. And if you go to clinicreviews.com and you go to on-demand courses, you can find the 21 plus hours of Nclex prep that Mark Klimek teaches himself. We also have a streaming service and small group tutoring. You purchase a month of tutoring and you get 4 tutoring sessions, and I do 2 of them. Piece of Art does 2 of them, and we do cover next gen in those tutorings, which is why I don't do next gen on the channel. All right, let's go ahead and get started talking about emphysema. You know, this is primarily an NCLEX prep channel. However, it is also good for any standardized tests that you may be preparing to take. If you have an exit exam or anything like that, this can help you. It can help you a little bit with review of content, but that's not my primary goal. So what I do is I assume, actually a lot of times I assume either you've been taught the information in class already, or I assume you've gotten the Blue Book that Mark Klimek published. You can get it at Amazon, and it's just a comprehensive content review, and it's not paragraphs of content, it's facts. It's just reviewing facts and things that you have to know. So my assumption is that you've either been taught this in class or you've reviewed the Blue Book. And now I'm just going to teach you how to answer questions related to this content. So we're going to talk about emphysema today. Before I get started, let me just say one thing. Emphysema is a loss of elasticity in the alveoli. So inhalation is active. It requires energy to inhale, but exhalation is passive. There's no energy required to exhale. It's like a rubber band. If you pull a rubber band and you let it go, it's going to collapse back down on itself, all on its own. I don't have to do anything to make it do it. I do have to exert pressure to stretch it, but I don't have to exert any pressure for it to go back into shape. However, if I were to put a rubber band, I have a cup here. If I were to put a rubber band around this cup and I were to leave it like that for a certain period of time, say a year, and then I took it off of this, it would have lost its elasticity. I would still be able to stretch it beyond the diameter of this cup. So let's say normally the rubber band was only this big. I stretch it around this cup, leave it there for a year. I take it off. It's no longer going to collapse down to this size. It's now going to be the size of the cup because it will have overstretched. I can still stretch it further, but I can't collapse it down. And that's what happens when we lose elasticity in the alveoli. It loses the elasticity, so it's no longer able to collapse down to where it was originally. So it's a destruction of that elasticity in the alveoli. And so exhalation is no longer passive. So you can exhale or inhale. You can inhale. And this is why they developed this barrel chest, because they get this bigger chest that is over stretched and loss of elasticity. And so now they go, normally you and I go, I'm going to hyperventilate if I'm not careful. But someone who loses that elasticity, and if they want to get down any farther, they have to exert a certain amount of energy. And that's why people who with COPD or emphysema is a type of COPD. It's one of the subsets of COPD. Bronchitis is the other subset. But anyone who has COPD or emphysema, they have to exert energy to exhale, which is why they get so fatigued when breathing. So when we treat emphysema, we do a lot of treating the fatigue of the disease. And we also have to manage really carefully gas exchange, because what happens when I exhale all the way down, I exhale all that CO2. But when I go, there's all this CO2 trapped in there, right? So sometimes, not everybody, but sometimes people with COPD, particularly with emphysema, have a chronically elevated CO2 level. We have sensors in our brain that detect CO2 and O2 levels. And these sensors in our brain, when it detects a high CO2 level, it stimulates us to increase our respiratory rate. When it detects a low O2 level, it stimulates us to increase our respiratory rate. So if the CO2 level is high, increased respiratory rate will lower CO2. If the O2 level is low, we increase respiratory rate, the O2 level will go up. So it balances that, right? Well, someone with chronically elevated CO2 levels, the body stops, it resets itself is what it does. It no longer senses that high CO2. I mean, it'll sense if it goes higher than normal, but it doesn't sense it. So we kind of lose that CO2 drive to breathe, and we primarily have an O2 drive to breathe. Now, it's not an absolute drive to breathe. It's not like if our O2 level gets high enough, we're going to stop breathing. That's not what I mean. We don't stop breathing. But what I'm saying is it has an O2 drive to increase or decrease respiratory rate. So if the O2 level gets high enough, 96, 97, 98, it slows down our respiratory rate because it says, oh, it's fine. We're doing gas exchange is good. And the CO2 level may be high, but if our respiratory rate slows down, we stop exhaling as much CO2, and the CO2 level can go up even higher. And then CO2 levels cause change in level of consciousness. If hypercapnia is the vocabulary word for high CO2 levels. So hypercapnia, it's an acid, and it causes lethargy, decreased level of consciousness, and so on. So underlying all of the things that we're going to talk about today is the fact that emphysema increases the work of breathing. That's number one. It increases the work of breathing. So we have to be careful that we're not fatiguing our patients who have emphysema, and they have a hypoxic drive to breathe. Okay, hypoxic drive to breathe. So, and then that's sort of pathophysiology. And then as far as respiratory treatments are concerned, there's only so many respiratory treatments that we have, y'all. We don't have endless amounts of respiratory treatments. We have bronchodilators, albuterol. We have steroids, prednisone. That decreases the inflammation in the lung, which there is often some inflammation in the lung related to the chronic disease. We can give oxygen, which increases O2. We can do pursed lip breathing, right? It increases that exhalation, blows off more CO2. So there's only so many things we can do. So when you think about these questions, think about the underlying problems: fatigue, hypercapnia, hypoxia, and then think about what treatments do we have. Don't pick some crazy treatment that you've never heard of before, okay? You got to use your common sense. All right, a nurse is assessing a patient with emphysema. Which clinical manifestation is most indicative of this disease? Persistent productive cough, decreased anterior chest diameter, expiratory wheezing, barrel-shaped chest. Okay, well, I know, and I have to make sure I'm reading it carefully. Which clinical manifestation is most indicative of this disease? Well, I know decreased anterior posterior chest diameter is not correct. Okay, so if you're looking at me from the side, if I have a barrel chest, the anterior posterior diameter increases for a barrel chest. So if the anterior posterior diameter decreases, that's not a barrel chest. So I know B is not correct. And I know persistent productive cough is more associated with bronchitis than emphysema. Now, COPD, the umbrella term, COPD, where emphysema and bronchitis are both part of that, I could say COPD may have classic signs of cough, but it's not asking COPD, it's specifically asking about emphysema. So I'm going to cross off A and B. Now, it is very common they have wheezing with emphysema. However, the one that is most indicative of the disease, and I know wheezing can occur with a lot of things. Wheezing can also occur with asthma, right? I know that. Whereas barrel-shaped chest, the barrel-shaped chest only, as far as I know, barrel-shaped chest only occurs when you have emphysema. I don't know of any other disease that results in a barrel-shaped chest. So when we read this question, you have to say, what is most indicative? So we're kind of looking at the thing that says this is unique to emphysema. That's what the question is really asking. And if English is your second language, it's important for you to listen to me explain these questions so that you can read them correctly. I know if English is your second language, I know you know what the words mean. Like I know what most indicative, you go, oh, I know what that means. But do you know that really what they're asking? Okay. And even if English is your first language, maybe you need to kind of learn how to read these questions so that you know how to answer them. Which physiological change primarily contributes to impaired gas exchange in a patient with emphysema? Impaired gas exchange is the O2, CO2 issues. Excess mucus production, alveolar wall destruction, bronchial hyperresponsiveness, or pulmonary embolism. Okay, primarily physiological change primarily contributes. All right, well, I know pulmonary embolism is out. That's not a physiological change. That's a disease, so I'm crossing that off. And I know excess mucus production is related to bronchitis, not emphysema. So I have to say, is it alveolar wall destruction? Now, I know there's changes to the alveolar wall, and I know the alveolar wall loses its elasticity. So B, if I'm testing conceptually, I have to say, is B the same conceptually as losing elasticity? And I have to go, well, it seems pretty similar. It seems like sort of a general way of saying there's a change to the alveolar wall. So B sounds okay. Bronchial hyperresponsiveness. Hyperresponsiveness, I'm not exactly sure what that means, but my guess is that it means it's prone to constriction, like there's prone to bronchial constriction. And that's not really emphysema. I mean, it can happen in emphysema. You can have an exacerbation of the disease, but that's not the underlying physiology that causes the change. It's really this loss of elasticity. So even though B does not say loss of elasticity, I know that it's a change in the alveolar wall. And I mean, if you lose elasticity, that's a destruction of some kind. So I got to pick it. So you have to test conceptually when you're testing on the Nclex or any standardized test that you're taking. You have to test conceptually. Don't say, well, I know the one word I'm looking for, and it has to be there. No, you don't look for the one word. You say, what's the concept they're testing? And I'm going to pick the answer that's most consistent with the concept I know to be true in this situation. Which factors contribute to the development of emphysema? So what leads to alveolar wall destruction? Smoking, viral infections, alpha-1 antitrypsin deficiency, high sodium diet, sedentary lifestyle, or air pollution. So let's turn this into a series of true-false questions. Smoking can cause alveolar wall destruction. Well, that's true. Viral infections can cause alveolar wall destruction. So this is where you can't overthink. Think in general, viral infections cause alveolar wall destruction. I've never known of a viral infection that causes alveolar wall destruction. Now, is it possible? Could it happen? It could happen. I'm sure it could happen, y'all. But the Nclex is testing general principles. So I have to say, in general, viral infections cause alveolar wall destruction. I go, no, it's an acute infection. You get over it, you're fine. So I have to say no to B. Alpha-1 antitrypsin deficiency leads to alveolar wall destruction. That's something you're going to have to memorize. That is true. So people who have emphysema or COPD almost always are smokers. Like 99% of them are smokers. But if they've never smoked, then you have to ask, do they have a genetic predisposition to this, which is an alpha-1 antitrypsin deficiency? It's a genetic disorder that leads to alveolar wall destruction. So C is correct. High sodium diets lead to alveolar wall destruction. No. Sedentary lifestyle leads to alveolar wall destruction. No. And don't say, well, it could. No, it couldn't. No, it couldn't, y'all. Come on now. Say, if you're like, well, I overthink. Okay, so then say, in general, sedentary lifestyle leads to alveolar wall destruction. Well, no. Okay, no. In general, air pollution leads to alveolar wall destruction. Well, yeah, I mean, air pollution. Now, don't say, well, it depends on how much air pollution there is. Okay. Stop overthinking. Seriously, I can't stop you from overthinking. You're going to have to decide yourself. You're going to have to police your own thoughts. But if you find you're going, well, maybe, then you are an overthinker. Okay. So air pollution in general, air pollution is known to lead to alveolar. Yeah, absolutely. That's why we say coal miners have a lot of problems, right? It depends on where you work. If you're exposed to a lot of air pollution, secondhand smoke could be considered air pollution. So all these things can lead to alveolar wall destruction. A nurse is educating a patient with emphysema about oxygen therapy. Which instruction is most appropriate? Most appropriate for oxygen with emphysema. Use oxygen at 6 liters per minute via nasal cannula continuously. Increase oxygen flow if shortness of breath worsens. Use oxygen as prescribed to prevent respiratory depression. Discontinue oxygen when symptoms improve. Okay, emphysema is a chronic disease. So whenever we're treating someone with a chronic disease, we never say discontinue this therapy when symptoms improve. We never say that. So I'm crossing off D. Now, C, use oxygen as prescribed to prevent respiratory depression. That's a really good Nclex answer. Whenever it says use something as prescribed, my ears perk up and I go, that's a good Nclex answer. So I really like C. Now, why would A and B be wrong? Do you remember when I talked about having a hypoxic drive to breathe because their sensors reset and it doesn't detect the high CO2 levels, and they have a hypoxic drive to breathe when they get up to 98, 97, 98, 99, it slows their respiratory rate. That's what happens when we turn oxygen up to 6 liters, or if just turning the oxygen up with shortness of breath. Like, we don't tell them that. We don't go, well, just turn your oxygen up, because it could depress their respiratory rate. So if they get shortness of breath, if it worsens, we're going to have other therapies we may recommend. Like, we may say use an inhaler. We may say do some pursed breathing. And then we may say, if these things don't work, then call 911 and come in and let us assess you. But we don't want to just say, turn up your oxygen at home with emphysema or COPD, where emphysema is a subcomponent of that COPD. We don't want to say just turn your oxygen up, because it could depress their respiratory rate. So we say use oxygen as prescribed to prevent respiratory depression. Which assessment findings indicate chronic hypoxia in a patient with emphysema? Chronic hypoxia. Okay, clubbing of fingers, hypotension, polycythemia, decreased red blood cell count, cyanosis, bradycardia. All right, chronic hypoxia. So if you don't know these, you need to know them. Clubbing of fingers. Clubbing of fingers is a sign. It's where the nail bed loses its roundness and it becomes very flat. So it's not only round this way, but it's also round this way. So it loses that roundness. So when you look at it straight on, it's just a flat nail. That's clubbing of fingers. That's a sign of chronic hypoxia. Hypotension, the pressure doesn't really have anything to do with that. So hypotension is out. Now you have to know what polycythemia means. Do you know what polycythemia means? You have to know what the word means. It means high red blood cells. High red blood cells. And the answer is yes. With chronic hypoxia, red blood cell production goes up because the body's trying to compensate so it can carry more oxygen. So polycythemia is a finding that indicates chronic hypoxia. Decreased red blood cells, the opposite. So no. Cyanosis, well, I hope everybody gets that one. Bradycardia, actually it would be tachycardia, because when they're hypoxic, the body increases heart rate to try to get more blood to pick up oxygen. So bradycardia would not be correct. What are common complications of emphysema? So complications are not the same as side effects. Side effects are the things you expect to see. So emphysema, you expect to see a barrel chest. You expect to see an increased respiratory rate. You expect to see a dropping O2 sat. You expect to see these things. These are complications, are things you don't expect to see. Pulmonary hypertension, bronchitis, cor pulmonale, pneumothorax, GERD, and stroke. All right. So what can happen? So emphysema is an increase in the size of the lung, which increases pressure in the vasculature. So when everything kind of expands, it puts more pressure on the vasculature. So pulmonary hypertension actually is a complication. Now, we don't want it to happen. It's not a symptom, it's a complication. It's a separate diagnosis, y'all. Okay. So if I say, you have barrel chest is not a diagnosis, it's a symptom. Pulmonary hypertension is a diagnosis, and it's a complication. It's a diagnosis that occurs as a result of emphysema. Bronchitis is a comorbidity, but it's not a complication. So emphysema doesn't cause bronchitis. Okay, they can occur together, but they don't cause each other. So no. Cor pulmonale, if you don't know what cor pulmonale is, another vocabulary word, it means right-sided heart failure. And it's a result, it's a complication of emphysema. So pulmonary hypertension and cor pulmonale, you have to know those. Those are complications. Those are things we watch to occur. Again, it's a diagnosis. Cor pulmonale is a diagnosis. It's not a symptom. Pneumothorax. So pneumothorax is where you have air escape getting into the pleural space. It's kind of spontaneously. Well, pneumothorax doesn't have to be spontaneous, but it can be spontaneous. And actually, it is a complication associated with long-term emphysema. So pneumothorax is a spontaneous pneumothorax, sometimes can occur. Again, pneumothorax is a diagnosis. It's a complication. It's not a symptom. GERD, no, it doesn't have anything to do with reflux. Reflux has to do with valves in the stomach and all that kind of stuff. No. Stroke, no, it doesn't. That's just not one of the complications of emphysema. For a client with emphysema, which of the following statements indicate they understand discharge teaching? For a client with emphysema, which of the following statements indicate they understand discharge teaching? So sorry for the typo. I will eat 3 large meals a day to ensure adequate caloric intake. I'll eat 6 small meals a day to prevent fatigue. So A and B are opposites. So one of them is probably one of the right answers. I will use a fan when I feel short of breath. I will increase my carbohydrate intake. I will limit my fluid intake to prevent coughing. I will make sure I get the flu vaccine every year. All right. Understanding of discharge teaching related to emphysema. So which is better, do you think? 3 large meals a day or 6 small meals a day? So remember, I said one of the things we care about is reducing fatigue, and eating actually and digesting food actually requires a lot of oxygen. And so it's better to do 6 small meals a day than it is to do 3 large meals a day. So you can get the same calories in 6 small meals a day rather than 3 large meals a day. So B is correct. I will use a fan when I feel short of breath. Okay. Well, I didn't learn that. Well, does it make sense? Does it make sense to use a fan when you feel short of breath? And it does. There is, I don't know if there's research on it, but it's pretty well accepted that if you just increase the flow of the air towards you, it helps people feel less short of breath. So yeah, that is helpful. I will increase my carbohydrate intake. So I think, well, do they want to increase their carbohydrate intake? I don't know if they want to increase it. I would rather they increase their protein intake. So I don't know. I'm going to put a question mark next to that. I will limit my fluid intake to prevent coughing. That's not true. That's absolutely not true. It may prevent coughing, but you've got to stay hydrated. That's you have to stay. We always want people to stay hydrated unless they're heart failure. Heart failure, we say limit your fluid intake. I will make sure I get the flu vaccine every year. I like that answer because people who get the flu often progress to pneumonia, which is a complication of the flu, and that can be a big problem. They're already at risk for pneumonia with emphysema. So yes, I like F. And don't say, well, I don't like vaccines. Look, I don't care if you don't like vaccines. You can say no vaccines for me if you want to. That's your business. But on the Nclex, they like vaccines. Okay. So don't be an anti-vaxxer on the Nclex. All right, let's go back up and make a decision about this carbohydrate intake. So for me, it's sort of like a 60-40. I'm pretty sure that it's wrong. I'm like 60% sure that you should increase proteins rather than carbohydrates, right? 60-40. And so I say, well, in general, do I tell people to increase their carbohydrate intake? Actually, it sounds more likely that I would say, in general, increase your protein intake. So I have to say, I would rather you underselect than overselect. It's just the way they calculate the answers. So if you're 50-50 on an answer, you just have to kind of make a judgment call. I'm 60-40 that it's not correct, so I'm not going to select it. And so it turns out that it is, in fact, not the correct answer. So I would say if you're like 60, 70, 80% sure that you are supposed to or not supposed to pick an answer, like go with your gut on that. So in general, what we say with respiratory disorders is we say increase your protein intake as opposed to increasing your carbohydrate intake. A patient with emphysema is prescribed home oxygen therapy. What precautions should the nurse include in teaching? Patient with emphysema is prescribed home oxygen. Okay, teaching about home oxygen. Keep oxygen away from open flames. Well, that seems obvious. Increase oxygen flow rate during dyspnea. We already know that's not what we're supposed to do with emphysema, so they don't depress their drive to breathe. Store oxygen tanks upright. That seems common sense. Remove nasal cannula while sleeping. No. Y'all, people become hypoxic at night. Sleeping is a really important time, actually, for them to wear their oxygen because our respiratory rate tends to go down. The depth of respirations tends to go down while we're sleeping, and they can become quite hypoxic at night while they're sleeping. Avoid petroleum jelly lip balm. All right. Have you ever thought about petroleum jelly having petroleum in it? That's not something I think a lot about, but I use a lot of Vaseline. I just use a ton. I live in a cold climate and I don't know. I just use a ton of Vaseline. Okay. But Vaseline is petroleum jelly, y'all. Okay. And it has petroleum in it. You can't use it when you're wearing oxygen. Okay. You can't. So that's really interesting, isn't it? Use bronchodilator to enhance effectiveness. Bronchodilators don't enhance effectiveness. So you might go, well, yeah, it would. Y'all, we don't use bronchodilators to enhance the effectiveness of oxygen. We use bronchodilators when the patient is bronchoconstricted, or they're wheezing. So I could say use a bronchodilator when you're wheezing, but I don't say use a bronchodilator to enhance oxygen. But it could enhance the oxygen. Well, it could, but what word did I say that you can't use? You can't use maybe, possibly, could, it, well, maybe, perhaps. No, you're not allowed to say any of that stuff. That's overthinking. Which medications are commonly prescribed for emphysema management? Short-acting beta agonists, anticholinergics, long-acting bronchodilators, opioid analgesics, corticosteroids, and antibiotics. All right, remember emphysema is not an acute infection, so we're going to cross off antibiotics. Don't be tempted to pick that. Go, wow, a lot of people with emphysema get pneumonia. You're right, but emphysema is not pneumonia, okay? All right, short-acting beta agonist, that is albuterol. It's a short-acting bronchodilator. If you don't know a short-acting beta agonist is a short-acting bronchodilator, you need to know that. Anticholinergics. So anticholinergics actually decrease respiratory secretions. So cholinergics, acetylcholine, which is the primary neurotransmitter of the parasympathetic nervous system. Acetylcholine increases mucus production. So if you give an anticholinergic, you decrease mucus production. So that is that's used, and you might go, well, but emphysema is not about mucus production. Well, it's not, but even if they just have normal mucus production, they have trouble getting it out because their lungs are overinflated and they have all these dead spaces where things can just sit. So we do use anticholinergics, long-acting bronchodilators. Salmeterol, okay, albuterol is a short-acting bronchodilator. Salmeterol, is a long-acting bronchodilator. Albuterol is the rescue inhaler. Salmeterol is what we use like twice a day or prescribe twice a day for them to use. So they don't have to use their albuterol. Opioid analgesics, don't overthink it, y'all. Corticosteroids, yes, to decrease inflammation. So these are pretty commonly prescribed. That doesn't mean they're going to get them all every time. It means they're commonly prescribed. That's all it means. Okay, that's it. I hope that was helpful to you. I'm sure it's not a comprehensive review of emphysema, but maybe it'll help you with some of the questions you might get and have a better understanding of what emphysema is, how it presents, and how we treat it. All right. Hope you have a great rest of your day.